Welcome to the podcast, Not Your Doc Anymore. I am your host, Daren Watts. Here we address the issues essential for your health and provide information to help you become your best advocate. We encourage empowerment through education. I cannot emphasize enough the amazing gift of those who understand clinical practice and are in the trenches on a regular basis and have had years of experience and are willing to share their passion with everyone. Here to address the topic of OB emergencies is Dr. Suzanne Welsch. Thanks for being here.
Thank you for having me.
The last time we were with each other is when we were doing our residency almost, has it been 25 years, 28 years
Yes.
ago at the University of Utah?
Yes.
It was great. I was talking to somebody about their residency and they just saw it's not real life. It's just so brutal. It was actually the time it was brutal.
It was. I don't think we realized it because we just didn't have the brain capacity to even process what was going on half the time. But looking back on it, it was something. It was brutal and really just some of the best years too. Just
for sure.
We got to learn and what we were thrown into, like it or not. It was a good time.
Yeah, so great. Thanks so much for agreeing to do this. I'm going to just tell everybody a little bit about your educational history. Suzanne attended Marquette University in Milwaukee, Wisconsin, got a major in physical therapy, then went to the University of Wisconsin and got a bachelor's in zoology. She then attended the Medical College of Wisconsin in Milwaukee, Wisconsin, where I also went to medical school. So we have that great Wisconsin link. And then to the University of Utah, where she did her residency in obstetrics and gynecology. She currently serves as the medical director for the Women's Hospital in Baton Rouge, Louisiana, but spent many years in Wisconsin prior to that. Is that correct?
That's right. I primarily did private practice for 20 plus years in the Madison, Wisconsin area. Mm-hmm.
Well, Suzanne, let's just start by telling everybody about your professional background and what led you to specialize right now in OB and GYN emergencies.
Sure. I went through most of my clinical career in private practice. So I did obstetrics, gynecology, did deliveries, took call, gynecologic surgeries. And an opportunity presented itself about 6 years ago for my husband to take over gynecology or gyn cancer division down here in Baton Rouge. The gentleman prior was retiring, and it was at a pivotal point in life where you think, I'm just going to keep doing this, or maybe I'm going to pivot and do something a little bit different. So he took the job, and a couple of years later, after our youngest finished high school, I moved down here with the intent to retire. I retired from my private practice, sold the practice, and came down here, and I got a little bored and started to do some shifts in the OB-GYN emergency department. So our hospital is unique in that it is the largest delivery hospital in the state of Louisiana. We do between 8,000 and 10,000 deliveries a year, and we have a dedicated emergency room for our hospital, which we call our assessment center. And we see a fairly broad range of OB and gynecologic emergencies. First trimester bleeding, pelvic pain, rule out labor. I think my water broke, vaginal bleeding in the third trimester, and then all of the post-operative complications that come in after hours as well, like wound infections, bleeding after surgery. We have a very large breast cancer practice and presence on campus as well. So we see post-operative breast issues as well as some of the post-operative gynecologic cancer issues for that practice. And as such, as an emergency department, we are licensed as such, and we see occasional men and children as well. So if they walk into our emergency room, we stabilize and treat those as well. So we work alongside emergency room physicians. There's one of us as OB-GYNs, and there's one of them 24/7. And together we work through all the cases, which is really nice if there's some knowledge I can lend to them. And then likewise, if there's some they can lend to me in the middle of an emergency, it works very well.
Wow. So how is that compared to running your own practice, what you're currently doing right now?
Yeah, I will say it is much, much easier.
Wow.
Yeah, as unpredictable as a 12-hour shift can be, a shift is a shift. And when you finish, you can go home and you finish your charts before you leave, and there's no after hours
Yeah.
phone calls. I would not perhaps have wanted to do it, right out of the gates, but as
Sure.
a stepping stone into a little less work, and it definitely has its advantages from that standpoint. Private practice was 20 plus years of many, many sleepless nights and,
Yeah,
sacrifices for family. And now I have just a little bit more time.
that's great. So
Mhm.
is it similar to an emergency room doc where you're doing 12-hour shifts through the month, 12 to 14?
Yeah. So, yeah, most of our OB-GYNs work 13 shifts per month, 12-hour shifts. I'm also the medical director there. So I work half of that number. And then the other time I spend working with nursing leadership and administration,
Gotcha.
policies, making schedules, chart review, patient complaint driven things, press gainy things, which is scorecard of how we're doing from the public eye standpoint. So yeah, I do both clinical and then some administrative work, and it's a nice balance. I've learned a lot in the last couple of years doing this.
That's crazy. I'm still trying to wrap my head around 10,000 deliveries a year. So that's what, almost 1,000 a month. How many labor rooms do you guys have that you're running?
You know what? It's upstairs on another floor, and when I have to go
Yeah,
up there, I get a little bit lost. There's
it's amazing.
maybe 40. There's several dedicated, obviously, C-section suites, and then the main operating room area. We, as the emergency room OB-GYNs, also cover any of the emergency deliveries. So if an attending isn't
Okay.
in-house or they're tied up with a C-section and they have somebody going fast through labor, that's our responsibility to run upstairs and deliveries or be a first assist on some of the cases that perhaps there's a lot of bleeding or that's a difficult delivery. So we're kind of a second assist on hold as needed as well. So we perform that role, which is kind of nice.
That's great. All right. Let's talk about some of the common conditions that you are seeing on a regular basis. And maybe let's start into the mental health part of that, and then we'll maybe go into some of the gynecologic part. Is that okay?
Sure. So
Yeah.
one of the big issues that we've had as I have started to work in this capacity has been the patients that have the perinatal mood disorders, which is about one in
Mm,
five patients postpartum. So depression, anxiety, and very rarely psychosis. But when you're pregnant or in a postpartum state, to have an evaluation for suicidality and have placement for that diagnosis is very tricky, and it's not ideal, some of the facilities that are available to this patient population. So our leadership here made a commitment several years ago to build out and place a 10-bed PMHU, perinatal mental health unit that's inpatient
wow.
bedded within Women's Hospital. So one of the big emergencies that we see are the population of what we call our PEC population, which is a physician emergency certificate patients. So those that are suicidal, homicidal, or considered to be gravely disabled. And these patients come in either on their own or at the encouragement of family or from a physician's office and are given a 72-hour hold by us. So we sign and say, these people are in danger to themselves or others. And that allows us to hold them legally against their will, if it's not their will, for up to 72 hours. And
Mm,
our PMHU has a capacity for 10 patients at a time, and we service any patient in any state of pregnancy or post pregnancy for up to a year. So, post
wow.
pregnancy could mean a delivery, fetal death, a miscarriage, an ectopic pregnancy, a termination of pregnancy, or any trimester of pregnancy. And this has greatly improved the care of our pregnant and post pregnant patients in that
Great.
there are psychiatrists trained to take care of this population and abilities if they are post pregnancy for babies to be brought in. And the unit was developed in accordance with safe furniture and safe carpeting and safe walls and safe mirrors, things like that. But it's a very tasteful, empathic, healing, soothing type of unit that was supported, by medical staff, leadership, nursing staff.
Wow.
It's a beautiful unit, and it's saving lives. So we think about emergencies as bleeding or infection or having a seizure or preeclampsia, things like that. But if you look at some of the obstetrical and or postnatal mortality, about 20% of mortality within the first year after a pregnancy is because of death by suicide. So it truly is an emergency, and we are able to give it now the attention that it deserves and the care that women deserve. And I think we're the 5th unit in the entire country in the United States that has a unit like this. So we are very unique. We're learning a lot with the unit, and we're also able to teach others about care in this manner. So it's been a very satisfying project, and we've been open for a year now, and it's really served the entire state of Louisiana, quite honestly. It's not just a Baton Rouge facility. We have people from out of state as well as mostly Louisiana, but it's a great resource.
You guys staying relatively busy on that unit?
Yeah, so interestingly, I think last week we had it was the first time that we were at capacity.
Oh,
Which is, it's unfortunate, but it's fortunate that we have the capacity to take up to 10 at a time. But it really has served a great need. Most of these patients also come through our emergency room. So part of our responsibility in the emergency department is to clear these patients medically to ensure that they can be admitted to this PMHU. So we have to make sure that they don't have a medical contraindication or a medical condition that really necessitates them to being admitted to the hospital side of our facility as opposed to the mental health unit. So that the treatment really is the mental health. They're not undergoing any medical treatment other than perhaps maintenance medications for their thyroid or blood pressure pills or things like that. But if they develop a medical complication, let's say they are pregnant and they go into labor, it's a very easy walk down the hallway through the elevator to the labor floor without the risk of, say, delivery en route with an ambulance or somebody ignoring them and saying, you're really not contracting, we're going to ignore you. You've done this to us before. So it's worked very well as a little bit of a back and forth between having a mental health unit, but yet having the medical specialists right there if something goes south,
wow. That's great.
Yeah, it's
What
a great model.
thing. That is a great model. Love it.
Yeah.
Let's maybe talk about some other common conditions that you may be seeing on a regular basis in your emergency room, either OB or gynecologically.
Yeah, probably the other largest population of patients that we see is the first trimester bleeding population. So those that are in their first trimester, which we would consider 12 to 13 weeks along, either by ultrasound or by a last period. And many don't even know how far along they are when they come in bleeding, know they're pregnant. So that population of patients probably makes up about 10 to 15% of all patients that we see. It can be very daunting to know that you're pregnant and start spotting or start bleeding at work, not having had your first obstetrical visit yet. So maybe you don't even have a doctor, you just have an appointment, you've never met them. So we're open again 24/7 as an urgent care / emergency room for these patients to come in without an appointment. They can just come in. And the issue with first trimester spotting or bleeding, obviously, part of the treatment is the psychological, emotional treatment and trying to at least get an answer for them as to what's going on. But the other part is to, again, make sure it doesn't represent an obstetrical emergency, such as a miscarriage in process or an early symptom of tubal or ectopic pregnancy. So those are the types of things that we try to figure out when they come in.
It's great. I would assume most bleeding in the first trimester would be considered abnormal. Would you say that? And needs to be
Yeah,
evaluated? What do you think
yeah,
about that?
yeah. I would say, no bleeding in the first trimester is abnormal.
It's not
Now,
true.
Now, that being said, what I also tell patients, because usually they are very frightened, they are very panicked, maybe they've had a miscarriage before. But what I also tell them is we're going to figure out what's going on. We don't know right now. We have some perhaps blood tests to do and physical exam to do and an ultrasound to do. So though all bleeding is not normal, not all bleeding means miscarriage. And so there's a sense of we need to figure it out, but we don't want to paint doom and gloom to them within, say, 5 minutes of meeting them. I would say at least half of them, it does not represent a miscarriage. So there are other things that can cause vaginal bleeding in the first trimester. And sometimes those are the answers, and it maybe has nothing to do with pregnancy. So it could be you had intercourse and now you're having
Yeah.
some spotting, or you had a bowel movement and you have a really bad hemorrhoid, and that was the blood that you saw in the toilet. And so we also have to consider some of the non-obstetrical or non-intrauterine reasons for the bleeding. But we also have to look at, is this a miscarriage? Is this what we consider a threatened miscarriage, meaning you're bleeding, it's not normal, the pregnancy is viable, but there's a little sign of a blood clot behind where the placenta is developing. There's a little bit of a hemorrhage by the ultrasound. We need to watch it. And usually those are the patients that we say, look, we know things are okay today, but over the course of the next 2 to 3 days, we need you to come back in and we need to look at it again. So those patients probably have the least reassurance and the most anxiety when they leave, because they got an answer, but they didn't get the reassurance. Everything is for sure going to be okay.
Sure.
And then the thing we don't want to miss, obviously that can lead to maternal death, is ectopic pregnancy or rupture of an ectopic pregnancy, which still happens in the United States today. I think Louisiana, we did experience one maternal death from ectopic pregnancy within the last year. So it can happen, it does happen, and we're really tasked to be on the lookout for those things that need further observation in the hospital or immediate treatment, be it surgery or medication for treatment of ectopic pregnancy.
So are you providing the comprehensive review of those patients? Like, I know you said come back in 3 days. Are they coming back to your clinic or your emergency room?
Yeah, we've made that commitment for those patients that are in the first trimester that don't have a physician, or it's a Thursday and we need to see them back Saturday or Sunday. We've made that commitment to say, just come back to us and we will do the complete evaluation again, do the follow-up, and close that loop for patients. And I think that's really important, because some of these patients are coming in at, we'll say 10 or 11 o'clock at night. And we always say, you noticed it at 2 p.m. Why are you coming in at midnight?
Yeah.
Or, but the reality of it is that women work and they either have to go home and feed their kids and get them in bed, and then they have time for themselves to come into the ER, or they work second shift or third shift and they're coming in when they're done with work. And so for you and I, that might be like 5 o'clock. They're going to come in. But, many of our working mothers just don't have the luxury of normal schedule or reliable childcare. And so the time that they have to, quote, go into a clinic or an emergency department is not a normal time of day. And we have to really adjust some of those expectations for the working patients, because they don't have time at, just come in now, 2 o'clock. Well, that's what the doctor office offered me, but I have my 3 kids
Can't
at
do
home. I don't have anyone to watch them until grandma's home from her job at 7 p.m.
But what a great service to be able to have a trained OB-GYN to come in to take care of these things.
Yeah,
So
I think it
nice.
makes a big difference, and it just closes the loop. They know where to go. They know they're going to get seen. And usually it's not too busy at 1 in the morning or 2 in the morning, if that's when they can come in. It's the same set of docs. So it's OB-GYN doc or an ER doc 24/7. And so they'll get the same care at that time of day than they will at 2 in the afternoon.
So let's talk a little bit about the typical evaluation that you will do for somebody who's experiencing first trimester bleeding.
Yeah.
I know you
So
talked about a little bit of that about
Mhm.
that. Some may be young physicians, some may be patients needing reassurance when they go
Mhm.
in.
Yeah,
Listen.
so I think in today's day and age where we have blood tests and ultrasounds and all that, I think it still comes back to a solid history. And I would contend that within probably 75% of the time, you take the history from the patient, you can formulate their diagnosis in your head, or at least take a guess and be right 75% of the time.
Yeah.
And I know the late, great Jim Scott, our chairman, would beat us with that information of,
For sure.
take a history, talk to the patient. They're going to tell you most of the time what is going on. And of course, you confirm with other things that we'll talk about, but listen to the patient. They'll tell you what's going on. Ask the right questions like, well, I was fine. I was just getting ready to go to bed. And then about 10 o'clock, I started bleeding. Well, did you have intercourse? Oh, yeah, we had intercourse at 9:30. And you bled at 10 o'clock. Okay. We're still going to make sure you're not having a miscarriage. You had some bleeding. It's not normal.
Yeah.
But again, you told me, I think, why you're having bleeding, and it's still okay that you're here, and we're going to reassure you. But so history, we got all kinds of technology nowadays, but I think the patients will tell you a lot of the time what you need to know. So history first, and then physical exams, very important, especially as it relates to first trimester bleeding. There are reasons that patients will have tenderness on exam and pain, and then there are other diagnoses where they have no tenderness or pain.
Mhm.
So I think isolating the pain. So some patients will say, I started with a dull ache in my right lower quadrant, and then it got really sharp, and it's still there, and it hurts a little bit now when I breathe. And you
Mhm.
press on their belly, and it's real tense, and they guard against you when you're pressing down, and you have to be thinking, I think this is a ruptured ectopic. And
Yeah.
again, they've told you, you've confirmed with physical exam, and then you go on to get blood and ultrasonographic testing to confirm. So history and physical are still really important for as much as
Yeah.
the medical environment has changed, and it's changed a lot since you and I started.
For sure.
That's still not to be ignored. So history, physical, looking at some of the laboratory testing. So urinalysis, sometimes the blood is actually blood in the urine, and it's not vaginal blood. So looking at what's called hematuria, or reasons for blood in the urine. Also making sure they are truly pregnant. So if they come in and say they're pregnant and you can't find anywhere in their medical chart that has been confirmed, do that first. Have them pee in a cup and make
Mhm.
sure they're truly pregnant, because they may not be. And then you go down a little bit different fork in the road. So
Totally.
blood testing, probably a couple of the most important ones would be, what is their blood count? Again, if there's pain, you're thinking ectopic pregnancy, or they're bleeding quite a bit. What is their hemoglobin? Are they anemic? Have they bled so much that you have to start thinking they may need blood? Checking their blood type is important. And then also checking what's called beta HCG. The beta HCG test is in the blood, the same substance that is checked on the urine to say yes or no, you're pregnant. But the blood test for the beta HCG can be quantified. And sometimes the number of how pregnant they are in that HCG, the number may not be important today, but the number may be important when you have them come back in 48 hours. That is to say, if that number goes up in 48 hours, it can be reassuring. If it stays the same or goes down, it can be a sign of a failed pregnancy. So getting and setting that baseline beta HCG when they come in for that first episode of spotting or bleeding can be very important. And then ultrasound also is probably the mainstay of trying to figure out whether or not there's a pregnancy in the uterus, there's a pregnancy outside of the uterus, or there's no pregnancy at all that can be seen. And sometimes in those cases, that means they miscarried at home. they describe a kind of a labor experience with the passing of a big clot, and they think they maybe passed the embryo, or sometimes not seeing it as totally normal. Maybe their HCG number is very low and they think they're 4 or 5 weeks along, meaning they just got a positive pregnancy test at home.
Yeah.
And you don't see anything because you're not supposed to see anything that
Right.
early. And that too can be reassuring and just needs follow-up, but
Well,
it doesn't necessarily mean anything bad. It's just gestational age appropriate.
it's great. Let's talk a little bit about an ectopic pregnancy and what that entails, what people should be worried about. And I assume, since you guys have provided such great comprehensive service, if that requires surgery, Suzanne, do you guys take them to surgery too?
Well, in my current position, I do not, since I have to stay in the emergency department and deal with all the
Okay.
other things coming in.
Well-
If patients have a physician that they have seen during this pregnancy or a past pregnancy from a couple of years ago, and they identify that person as their physician, then we call that physician or the call group.
Okay.
But for the unassigned patients, which tends to be a pretty big percentage in the first trimester, we do have a residency program here through LSU or Louisiana State University. So
Okay.
they have attendings and residents, and the unassigned patients, we consult that attending group for the unassigned. And so the surgery or the decision for medical management of the ectopic pregnancy goes to the LSU residency group.
All right. Let's just give a brief overview of when do you medically manage a patient with an ectopic pregnancy and when do you surgically manage them?
Yeah. I think when you and I were in training, this medication called Methotrexate was just coming out and being utilized, and really guidelines for usage of Methotrexate were coming out and being modulated a little bit. But Methotrexate is a chemotherapeutic medication given into the muscle as an injection to basically destroy the cells that are growing in a pregnancy. And so that can be an option for treatment of an unruptured ectopic pregnancy. And there are some guidelines in terms of the size of the ectopic pregnancy, the number that HCG level is at, that really change the decision whether or not we think this is a good candidate for usage of methotrexate. Now, the other thing that I will add is we can look at guidelines and check boxes and say, yep, they totally qualify for getting methotrexate. But I think the other thing that we really have to look at with these patients is, should they be getting it? And by that, I mean, we have to look at some of these socioeconomic factors that are involved with utilizing methotrexate, because methotrexate does warrant follow-up and checking HCG levels, making sure patients have transportation to come back if they do experience a rupture, which can happen after methotrexate. So not all patients that qualify for methotrexate should get methotrexate. And part of the teaching in terms of the residents is this patient doesn't have a car. This patient is homeless with 2 children. And if you send her back out with methotrexate, she's not going to come back into your clinic in 3 days to get another HCG level. So working through some of the social determinants of health really needs to be taken into account. And the other thing is, some patients, and one of the big risk factors for having an ectopic pregnancy is having had an ectopic pregnancy before, or having had tubal surgery, like a tubal sterilization procedure that has now failed, resulting in an ectopic pregnancy. So I think that's not to say that those patients shouldn't have methotrexate, but I think a really concerted discussion with patients is necessary, because if they have a damaged tube and you know that tube is damaged either by having had it ligated, but not really because there's a pregnancy in it now, or prior tubal surgery for, say, a tubal ovarian abscess, or maybe even a ruptured appendicitis on the right side, giving them methotrexate and not taking care of the tubal damage issue can certainly put them at risk their next pregnancy for an ectopic pregnancy on that side again. So again, methotrexate has a role. There's check boxes to make sure that they have the right number of HCG and the right centimeter size of the ectopic. But I think you also have to look at the whole patient to see if they are a good candidate for follow-up and for methotrexate to begin with. So then the other option is, if you don't give them medication, is giving them surgery. And so ruptured ectopic pregnancies, somebody who had a pregnancy grow in a tube and rupture into the abdomen usually implies that there's blood in the abdomen and perhaps ongoing bleeding as well. And so those are truly surgical emergencies. Those are things that women still die in the United States from. So those patients, when there's evidence of rupture, blood in the belly, and a kind of an ill-defined mass, which is usually the ectopic plus blood and blood products, those really need to go to the operating room very quickly with some blood on standby. They can bleed very quickly and need blood transfusions as well.
That's not great. Those are crazy times. Speaking of the times when it first came out, I remember, I won't mention who the doctor was, but I remember a doctor and a group of doctors who would do the surgery and then give them methotrexate right afterwards, just to make sure. And I was like, what on earth are we doing here? This is when they were just trying to figure out protocol, and they're like,
Right.
well, hey, we're just going to be doubly sure. We're going to do the surgery and give
Right.
methotrexate.
If one thing is good, two things are better. Yeah. Yeah. And
The
I think
worst of all worlds.
I think some of the guidelines for usage of methotrexate have really broadened as we've gotten more comfortable with it and realized that fertility is no different, if you have methotrexate versus surgery. And so how we use it now is certainly different than 30 years ago. And, sometimes surgery plus methotrexate can be indicated, right? You do surgery, you don't take out the whole tube, you just open up the tube, you flush out the ectopic, you check that HCG, and maybe it just never drops to zero, but you know that you took the ectopic out because you have a pathology report that says that was trophoblastic tissue or pregnancy tissue. So sometimes you then need to also give them methotrexate after surgery, but to just do it. It is a chemotherapeutic agent, and that it has some risks with it. So to just give it probably wasn't the best thing to do back then.
I remember talking to Jason Johnson, one of our great friends together, about this, and he said, how much is your largest blood loss?
Oh boy.
Yeah.
Probably 3 liters of blood, ruptured ectopic, and then by the time we get them in the OR and the ongoing bleeding and suctioning out and actually finding what it is that's bleeding, I bet it's bordered on 3 liters. So, interestingly, I would contend there are a couple of surgeries in gynecology that patients wake up after having had abdominal surgery with incisions and anesthesia and all that they wake up feeling better after having skin incisions and all the manipulation that go along with surgery. Then they feel better than when they came in. And one is getting rid of that ectopic pregnancy. They wake up and they go, I feel great.
Sure.
I could walk out of here now. I feel so much better. And the other is what's called ovarian torsion, where the ovary twists upon itself on the pedicle with the fallopian tube. Those patients are just in sheer misery, and you fix that torsion, you take out the ovary, untwist, take out the cyst. They wake up and they're like, oh yeah, I feel great now. And those can be satisfying surgeries because you've actually just fixed their problem. But it's pretty rare to wake up from a surgery and have patients feeling like better. They have no pain. They're like, oh no, this is nothing compared to what I came in with.
Yeah, right. Those knee replacements are probably not that, right?
Right.
At first. Right. Later on they are.
Right.
We're going to just maybe span the 30 years in our practice. Technology has improved with the diagnosis and management of first trimester complications. Any thoughts on that?
Well, yeah, for sure. The mainstay of ultrasound usage and really the ability to see things better with ultrasound. The clarity of ultrasounds now is a lot better than 30
Amazing,
years ago.
isn't it? Yeah.
And just using it as a third hand, right? I won't say everybody gets an ultrasound, but it's just such an
It's
easy
close.
tool to use to elucidate so many things. Whereas again, we go back 30 years and to diagnose an ectopic pregnancy, I mean, as a medical student, it was you get a pregnancy test, you get an HCG, but boy, that took probably an hour and a half to 2 hours in the lab back then. And then you do something called a choledocentesis, which is putting in a speculum into the vagina and taking a needle and putting it into the back of the vagina and withdrawing fluid. And if you got blood, you knew it was in a ruptured ectopic pregnancy. I think if you mention that to any of the residents nowadays,
They're
they
like,
probably
what?
say like, call security. I don't know what this lady's talking about. Like, we don't do it. That's torture,
So
And we've seen choledocentesis in my day, and I don't even know that's in a textbook nowadays because we have such clarity with ultrasound that we don't need a needle in the back of a vagina to draw blood from and say, oh, that's what it is. So that is a historical note about ectopic pregnancies that we just don't use anymore because of ultrasound. And I think also technologically, again, we can have, our laboratory scientists are to thank for this. They can turn out these lab tests with these analyzers so quickly. So, they can give us a beta HCG result within an hour, and they can give us a urine pregnancy test. We can get some CLIA waived on-site testing that we can just do it ourselves down in the unit and not have to actually send urine upstairs to even get that pregnancy test to get the workup started. So I think in the lab as well as radiographically, it's really been a game changer for ectopic pregnancies, really first trimester bleeding in general.
That's great. When we talked earlier and you were telling me about the value of the history and the physical, and I think that I could just hear Dr. Scott and all of the people that trained us just embed that into how we treat patients. And it's so great to see that you're still doing that 25 years later. And that's how I've felt for so many years of my practicing medicine. But we've come into an interesting time where patients have so much information thrown at them, some on social media, some online. How do patients navigate all of the information that's coming to them about first trimester bleeding? And how would you advise a patient that you're talking to or telling right now?
Yeah. Well, they come in having consulted Dr. Google, and then they come and talk to Dr. Welsh. And, there's a lot of, but what about this? And what I try to tell them is, you're looking at all the possibilities. I'm looking at you as the patient, and I'm looking at your symptoms and at what you are telling me about your situation. And so all of those things can't possibly apply to you at one time. You're going to have one of those things of the 10,000 that Dr. Google in that rabbit hole told you all about. And so what I try to have them just focus on is, this is you and this is your situation. And there's not a website about you, Google, right? That this is just you, and this is now your information. These are your labs. This is your ultrasound. And this is what that means. And the fact that you have an intrauterine pregnancy that's 9 weeks, that has a heartbeat, ectopic pregnancy no longer applies to you, even though it was on the Google search that you came up with. And I think a lot is to be said about really allaying their anxiety and listening to the questions that they have. When I took over the assessment center, we didn't have the emergency room physicians, and we don't have kind of the staff that we had now. But what we really had a problem with in terms of patient complaints on some of our what's called Press-Ganey surveys that would come back to us was that they didn't feel like all their questions were being answered. And we were scoring very low, both from a nursing standpoint and a physician standpoint, about
Okay.
overall satisfaction as it related to communication. And I had always very much prided myself in my private practice about answering questions, feeling like patients were listened to
Yeah.
across their lifespan. And so what we did was the first year that I took on medical directorship was we did some empathy training, and we had a perinatal counseling service come in, and we made it mandatory for all the staff, the nursing staff and the physician staff and the APPs to just learn techniques of not necessarily how to talk to patients, but how to listen to patients. And a lot of the complaints were because of first trimester bleeding and miscarriage, because again, that was a great percentage of the patients we were seeing.
Mhm.
And we went from an overall physician and nursing satisfaction in the 60s, 60 percentile when I started, up into the 90s now. And I think
Wow.
it really makes a difference if you listen to your patients. And I think a lot of times we can talk, but I'm not sure we always listen. And
Mhm.
I think when we listen to patients, their satisfaction with their care is so much greater. And when we take the time and we sit down next to the patient and not stand over them, even their perception of how much time we've spent with them is greatly improved if we just sit down. And so we've changed up a couple of things, not that our medical care is all that different, but just how we communicate to patients and how we listen to patients has greatly improved their care. And that's important because I think nowadays
Yeah.
there is some reluctance and some
Mhm.
reservation about seeing a physician or trusting the medical institution. And it really behooves us to establish trust in smaller situations so that in bigger situations, they're more likely to come back to see.
Mhm. It's great. Would you be willing to share an anonymous story or experiences that highlights the importance of seeking timely medical advice so that we can maybe harp on this point? Because I know that we've got some people who may brush it off, some people who are probably overly anxious and keep coming in. But when is it, I guess, the most appropriate time to
Mhm.
come in for this kind of care?
Well, I think, again, the hope is that as these women have grown up and gone to their family docs or pediatricians, that they've had good experiences within the medical establishment. I think that's first
Yeah.
and foremost, because that will allow them to come in for more timely care. They're not going to brush it off. So I think probably I can give you a really great example of this, probably as it relates to another obstetrical emergency that we see another probably 10 to 15% of the time. And that is high blood pressure of pregnancy or
Hmm.
hypertension
Sure.
disorder in pregnancy. So, and I was working just within this last month, and we had just a lovely, normal, healthy, first time pregnant patient come in, mid-20s. She took prenatal vitamins. That's it. Very healthy, healthy habits, ate well, exercised throughout her whole pregnancy, and woke up that morning and just thought, I don't feel so good. And she was 35 weeks pregnant and was on that schedule to go in to see her OB every 2 weeks, which is pretty normal after about
Yeah.
32 weeks along. So she's 35 weeks. She had seen her doc the week before, and she's planning to see her doc the next week. But she woke up that morning, just said, I just don't feel right. I know my body, baby's fine. It's moving well. I think I look a little different in the mirror. I slept pretty well, but my eyes look just kind of puffy. I can't get my ring on my finger, and my shoes do not fit today. So she was very
Wow.
swollen and kind of talked over the nurse line. And the nurse said, well, swelling's pretty normal in pregnancy. Why don't you just rest for a little bit and call me back in an hour? And she just woke up, rested, and called the nurse back, said, something's not right. I know myself. And she came in, and her blood pressure was the highest of the day. it was 180 over 110. And just for reference, most pregnant patients should run a blood pressure of less than 140 over 90. So 180 over 110 is what we would consider a severe range blood pressure. And that patient really saved her life and the life of her baby by coming in. And preeclampsia is also one of those things that it can just come out of nowhere, right? There's a lot of people who have high blood pressure and have risk factors and are getting watched for all the things over the last couple of weeks of their pregnancy. But there are some cases of preeclampsia that just pop up one day. And so she sought care, just knowing herself and knowing her body, and really needed to have that baby at 35 weeks. And she did fine, and baby's healthy. Baby did fine, even at 35 weeks, a little bit early. But that could have been, I'm convinced, 2 days later of ignoring it and just it would have been a different situation in the ER that day. I really gave her kudos and said, you saved your life and the life of your baby by coming in.
Right.
Good call.
It's always great when patients have those intuitions, and I think they have them quite often, don't you think?
Right. So you have to listen to your patient. And like I said before, they'll tell you many times what's going on before the physical and all the fancy tests.
Okay. Well, this is awesome. And this next segment of what we're going to talk about is what I refer to as the Delta segment. Being involved with this kind of patient, and I'm just going to say obstetrics and gynecology because I know you're doing emergencies more right now. But how has this changed you?
Well, I think there are many ways that this field can change someone as an individual. I think as a parent, it has allowed me just through medical training to know when my kids have really been sick and really have needed emergency care and when they just need to suck it up and go to school. So I think I can tell the difference between the two of those just over the lifetime of their illnesses. I think it has allowed me to become someone in the family that family members can call and just run things by and say, not that I'm going to diagnose them or treat them, but I can give them advice like, I think you can ignore that, or no, you need to go to the doctor. You need to call your own doctor and get that figured out. I think it's also allowed me to have an appreciation of some of the conditions in women's health that it doesn't get the sparkle and doesn't get the banner. And that really, for me, probably over the last 5 to 10 years has been maternal mental health. I've become part of a nonprofit back in my home state of Wisconsin and helped run a suicide prevention and education event. It's a 5K, just a fundraiser every year.
Awesome.
And I've done that with one of my other fellow OB-GYNs in town in Madison, Wisconsin, who lost her father from suicide about 10 years ago. So she and I have been running, it's called Beat the Blues, and it's geared towards mental health awareness in youth and older adults, male, female, doesn't matter, cuts across all socioeconomic strata. So having an understanding that the mental health of a person can very much dictate their physical health and also their physical health in terms of their nutrition and their exercise really plays into how they are best equipped to fight diseased state. I've seen a lot of focus, especially when I was doing more primary care, women's health. I did a lot of teaching about diet and physical activity and exercise and meditation and yoga and just wellness activities to complete somebody's health picture. And that's been a really big part of my life personally.
That's great. So I have a book club that I started about a year and a half ago, and a bunch of men. It's been amazing.
Mm.
but our last conversation was about mental health.
Mm.
And the statistic that we talked about that I thought was so shocking was that the age group that is the highest for suicide is over 60-year-old men,
Yeah.
and by a long shot.
Right. Right.
It's so
Yeah. My best friend's father, the one that the event is centered around, that was his demographic. So
wow,
it,
so
yeah,
sad.
it hits home.
It does. Well, I'm constantly having conversations about concerns that people have about what they refer to as the broken healthcare system. How do you feel like we can improve on the care of an individual? It's a pretty broad question.
hmm Well, I've again, through mostly doing primary care to women, I think prevention is key. Preventive health is really where it's at. It's pennies on the dollar for prevention compared to treatment of a disease state. So I think making sure that nutrition is there and the exercise is there. And I think making sure that food availability and good choices of food is available for children. In my private practice, I worked primarily with family physicians, and really their struggle with treating and educating about childhood obesity was really dramatic. And I think until we prevent many of the things that we ultimately end up treating later, that's really our ace in the hole, is
Yeah.
trying to prevent disease. We have lots of chemotherapy and radiation. We got everything to treat all the bad diseases, but um, I don't know how to just impact the prevention piece, whether that's through home or school or community centers. I don't have the way to figure it out yet. Maybe that'll be my third. When I hit
Third prayer.
65, maybe that'll be my next retirement project.
Yeah, I love it. It's so good. Good. Well, thank you so much, Suzanne. I'm just going to use this as a final charge that if I could encourage each person to use this knowledge to go forward and improve your health, seek out a healthcare provider that can get you the most appropriate care, or urge a loved one to do the same. If you are a healthcare provider, go forward with greater knowledge to deliver the best healthcare in one of the most vulnerable and essential interactions with those who are entrusted to your care. And we just need to clarify that the medical advice or procedures do not substitute for your own professional medical consultation. In addition, listeners or viewers need to be aware of the limitations of the information that we provided generally. And you can find this on Apple Podcasts, Spotify, Amazon Music, and YouTube at Not Your Doc Anymore. You can also find us on Instagram and TikTok either at Not Your Doc Pod or Doc Watts _. Thank you to all those who made this possible. Natalie Watts, our president and CEO of Not Your Doc Anymore LLC, our social media managers, Taylor Seberg, Emily Brown, Sarah Marion, and our production manager, Joshua Watts.